a neonatal intensive care nurse in Brisbane, Australia, before moving to London in 2023. She has held various roles, including neonatal clinical nurse consultant, neonatal sister, and is currently the clinical governance lead for the Evelina neonatal unit. She has a master's degree in advanced clinical nursing, majoring in management and quality improvement. While Ebony feels passionately about improving all aspects of neonatal care, her particular interests include neurodevelopmental care, care for extremely preterm infants, and change management. Thank you, Ebony, for delivering this talk. Over to you.
Hey, hi, can everyone hear me okay and see me okay? We've got some of our nursing staff in the room, so I'm going to present to them. But yeah, follow along with the slides, and if you have any questions, let me know. So I thought it was really important that we had some of our nursing staff in the room today, given that this talk is about the nursing perspectives of investigating and improving unplanned extubation rates in a tertiary neonatal unit, which has been a big focus for our team in the past 18 months, as we've sort of implemented the Secure project, which I'm going to talk about today. So the aims for today, so we're going to do a bit of an overview of unplanned extubations in the NICU, why we care about them. I'll go through that because I assume that everybody that's on this call really cares about unplanned extubations and probably already knows all this information. Why unplanned extubations matter in our vulnerable population. We're going to talk about the critical role of nurses in unplanned extubation prevention and the subsequent challenges that we face at the bedside. And then I'm going to share a little bit of our local multidisciplinary quality improvement initiative that we've put in place to reduce unplanned extubations, and that's called Secure. Okay, so just to start off with, so we all know that an unplanned extubation occurs when an endotracheal tube or an ETT is dislodged or removed without prior planning for its removal. So it's a serious adverse event, and we know that it can contribute to a variety of things, including airway trauma, hemodynamic instability, infection, and parental anxiety. So unplanned extubation is a recognised problem in all intensive care areas. However, it's one of the most commonly reported adverse events in neonatal care. As we know, it happens in PICU and adult intensive care, but it happens a lot for us as well. So why are neonatal patients at a higher risk of unplanned extubations compared to adult and paediatric populations? So we know that our babies are extremely small. They've got a short trachea, which means that the endotracheal tube doesn't have as much room doesn't have to move as far, and it can be very easily dislodged. We try not to routinely sedate our babies, probably compared to adult and paediatric populations. We know that sedation is not particularly good for their neurodevelopment. So if possible, we very minimally sedate them, and they're certainly hardly ever paralysed. We know that our babies, particularly those born extremely preterm, can be intubated for a really long time. So obviously, the longer that you have a breathing tube in, the higher the risk of unplanned extubation. Unfortunately, there's no perfect method of breathing tube securement, otherwise we would all be doing it. So there's significant variation in practice. Personally, here at the Evelina, we use the Neo bar. However, we know that you can also use hat and ties, tapes, and what's the other one? The NeoTRIPs. Yes, yeah. We know that compared to adult and paediatric populations, our neonatal patients are handled and moved regularly to try and facilitate family-centred care and skin-to-skin. So that happens quite a bit compared to other populations. And unfortunately, here at the Evelina, but also in other neonatal units as well, we don't have the funding to routinely nurse our intubated patients one-to-one. So the staff at the bedside are often sharing responsibilities between other babies, rather than just sort of keeping focus on that breathing tube and the one patient. And you can see here some pictures of our tiny little babies, which give context to why unplanned extubations are so prevalent in our neonatal population. So unfortunately, incidence of unplanned extubation varies between neonatal units. And if you look at the literature, it is quite varied. Some units are aiming for less than one unplanned extubation per 100 ventilator days. That's certainly not the case wasn't the case when we started our project. And there's quite inconsistent reporting of unplanned extubations. So we've been working really hard with our project to make sure that all of our unplanned extubations are reported on our Trust incident reporting system. However, we know that sometimes they can slip through the radar and not be reported consistently. So in terms of our data, so when we first started this project, we established that we had a baseline rate of 4.9 unplanned extubations per 100 ventilator days, which if you look at the literature is quite high. And 75% of our unplanned extubations were occurring during patient handling as well. So that was something that we pulled from our incident trends. Okay, so now looking at our nursing challenges in terms of reducing unplanned extubations. So as the clinician at the cot side, around the clock, neonatal nurses are key to reducing the incidence of unplanned extubation. Do we know why? Why are they key?
Because we have the most contact with the baby.
Yep.
Neonatal like 27 generally.
Yep. Anything else?
We monitor the tube.
Yeah.
Keep an eye on who else handles the baby.
Definitely.
Support parents.
Support the parents. Yeah, a few big ones there. Okay. But we know that we face a lot of challenges, so it's not quite as easy as what it looks on paper to keep a breathing tube in. We're going to explore them a little bit now. So workload and patient acuity, probably one of the biggest ones. So as I mentioned before, often in neonatal units, we don't have the funding to nurse our babies one-to-one. And of course, when you're not having direct oversight over one baby and you're sharing responsibilities running back and forwards across the room, things can happen when you're not having complete oversight. So we know that being able to nurse one-to-one would probably, have a really big impact on reducing our incidence of unplanned extubation. We also know that neonatal patients are really becoming sicker. We're providing treatment and care for smaller and more fragile babies as medicine advances. So our workload and our acuity has become significant. And I'm sure that those that have been a neonatal nurse for probably longer than me can attest to that. And I know there's some of you in the room. Time. So when we're having to look after a bigger workload and more patients, we don't have the time to spend, as much time at the bedside, making sure that everything is perfect, that our tubes are secure, that our babies are comfy, that they're not moving around. So that has a really big impact on unplanned extubation. Lack of standardization and education. So as I said before, that, we don't have a standardized method for securing our breathing tubes. We use the NeoBar here, but at admission, we use a hand ties. So staff have to be familiar with using two different types of securement methods. And I know that that's something that we're working on. And education, really having that, those guidelines ingrained in and education ingrained in our practice of how we should be handling our babies, why unplanned extubation shouldn't happen, and what we can do to try and keep babies safe. Balancing competing demands. So I think that this is a nice way of looking at all we have to do in our 12-hour shift. But one of the biggest things that we sort of have to compete with is the families. And, we practice family integrated care here at the Evelina, so they're partners in care. So we're trying to involve them as much as possible, but also keep our babies safe. We're trying to facilitate skin to skin. We have a standardization that we need 3 trained staff members to get any intubated baby out for skin to skin. That takes a lot of time. So, those things all contribute. And I know I've certainly been in a position where you're under a bit of a time demand, you've got feeds due, mum wants to have skin to skin, you can't get the staff members, okay, no worries, we're just going to get 2 people to do it. And you're compromising the safety of the baby, but it's because you're under quite a bit of pressure. Understanding the significance of unplanned extubation. So I suppose it comes back to education about, our team coming through and understanding that unplanned extubations, we don't want them to happen, why we don't want them to happen and what we can do to make sure that they don't happen. Culture, asking for help is not a weakness. So when you're not nursing the baby one-to-one, there's not enough staff members in the room to sort of do things like, oh, can I have a second person to handle this baby? Or, oh, no, everyone's busy, so I'm not going to ask for help. But actually understanding that, we need to have a culture where asking for help is okay, because at the crux of this, we're kind of trying to keep our babies safe. So that's definitely something that we've been working on, that, it's okay to pause and ask for help. But again, there's lots of things that contribute to not being able to ask for help. And one of them comes back to ratios and time and acuity. And the emotional impact of being involved in unplanned extubation, so feeling at fault or to blame. So I think it's important to recognise that not all unplanned extubations are preventable, and a lot of them actually, there's nothing that you could have done. Sometimes they do just happen, and we know that our patients are particularly vulnerable to them. But I know I could put my hand up and say that I've looked after a baby that's had an unplanned extubation and you always feel awful and you always feel like it's your fault and you take that home. So I think that that's just something to recognise that, we all really care and it does have a big impact on how we feel as clinicians. I'm going to turn to the room. Does anybody have I missed anything in terms of our nursing challenges, or can anyone weigh in on how it feels to actually be nursing these ventilated babies at the bedside?
I think the workload is the biggest challenge, I would say, because I think it contributes to so many things. For example, we knew that our babies aren't routinely sedated, and when you're dividing your time between two babies and helping in the room, you also can't keep your intubated baby as settled as you would want to. And sometimes that's a cause for self-extubations, as we know. So not being able to give them enough kind of that 24/7 eyes on the tube and keeping them settled so that they don't remove the tube themselves.
Anyone else?
I think the culture is still like a thing that's a work in progress. Like that's going to probably take a fair amount of time for people to get used to that, because there are many people that you still ask for support with something like that, like repositioning or whatever, and they just look at you sideways. Like I think
Historically, we've always done it on our own.
yeah, so I think that will just take time to continue to improve on that.
Definitely. Yeah. And I think that when we're looking at change management in any form, change is really hard. We know that it's one of the biggest barriers in quality improvement. And when we're competing with so many demands that we've listed here today, sometimes you just want to come in and do your job and not have things change. So I think that that's something to recognise as well, that change can be exhausting, even though we know that it's better for our patients and ultimately better for us as well. Okay. So I also just wanted to sort of mention to our medical colleagues, and I think, this is a point for discussion, that nurses sometimes feel like they can't contribute to meaningful change. And we know that this isn't the case. And for context, quality improvement isn't as well established in our university courses when you're coming through. It's something that I think is definitely changing, but I know that when I first qualified as a nurse and was working on the neonatal unit, when someone offered me the opportunity to be involved in QI, I was really surprised and felt like, oh, well, what do I have to contribute? And I'm not sure if others in the room feel the same, that, probably compared to our medical colleagues, we just feel like maybe, we don't have a role to play, but actually that's absolutely not true. And it's definitely something that we've been trying to work on here. And I know that with our project, that the nursing team have been crucial to drive the change and crucial to the success of the project. What do you guys think about that?
Yeah, I agree that we haven't traditionally had quality improvement education in our training as nurses. You kind of feel like your role is a bit more task orientated, like you're just completing tasks at the bedside. But this quality improvement project has probably helped a lot of us to realise that actually we're there advocating and we can be involved in quality improvement and implementing best practice for the babies, because we're at the bedside all the time.
And here, especially with the biggest amount of manpower workforce wise, like we probably have the biggest impact.
Yes.
There's so many of us.
Yeah.
So as long as things can be distributed to the right people and everyone's empowered enough to feel able to help with the change, then I think we're the best people to do it.
Definitely, I agree. So you can see here as well, I just wanted to point out that this is two of our nursing staff enjoying one of our awareness days for our unplanned extubation project, which I'm going to talk about coming up. All right. So reducing unplanned extubation nursing staff are the key to success. So what's important? A multidisciplinary approach to all change management. This is essential to drive change. So not just for unplanned extubations, but for all quality improvement. If you don't have an MDT approach, your change just isn't going to happen because you're not going to have enough stakeholders involved on the floor and actually making that change happen. So that's something that's been really important to us when we've been looking at our unplanned extubations, that we have a wide variety of roles and also experience levels driving this change. I think it's important to be realistic as work is done versus work is imagined, and understanding that challenges differ depending on your role. So I think we've identified a lot of challenges that the nurses face. So that was something that certainly with our project we've had to overcome. So we don't routinely nurse our ventilated babies one-to-one. So it wasn't appropriate for us to standardise two-person handling and positioning, even though we know that that is the gold standard. So we launched two-person handling and positioning as the gold standard, but we also implemented alternatives such as, having the baby swaddled in a muslin so that you can handle them safely and focus on the breathing tube. rather than, because, it was just something that we weren't going to achieve at this current stage. So I think that is really, really important. There's no point putting in change ideas that are just simply not going to be achievable by the staff on the floor. I think seeking feedback before, during, and after making changes, this shows that you're listening. And this was definitely something that we did for this project. We sought feedback through surveys from all of our MVT before the project, during the project, and then we will do it after the project as well. And we actually acted on that feedback as well, which is really important. So we changed a lot of our ideas and did various PDSA cycles based on feedback that we actually got from nursing and medical staff on the floor. And I think what's really important is to find those most passionate and employ them as champions for change. And I think that comes back to, engaging nursing staff in quality improvement. Sometimes we don't feel like we have a role. We absolutely do. And some of us are the most passionate about these things on the floor. So find those key people, get them involved, give them a role. And that's where your change is going to happen. And that is exactly what we've done for this project, because quality improvement is so hard. Change is so hard. And you've got to have the right people with a lot of passion, endless energy to make this happen. So that is probably one of my biggest secrets. Find those people and use them because they've got the passion. And get creative, making a unit-wide commitment to doing better, which is exactly what we've done with Secure. We've engaged as many people as possible. We've found various opportunities to create awareness for this project. And we've had a lot of fun doing it actually, and we've had some great results, which I'm going to share now. Okay, so just a little bit of context about our unit. So obviously this is the Evelina neonatal unit. We're a tertiary hospital in London. We have a 20-cot ITU as well as a HDU and a special care. And we cater for preterm babies, as well as we take specialty referrals for cardiac and surgical babies as well. So we see a wide variety of patient populations within our neonatal unit. And as I mentioned before, that we don't routinely nurse our ventilated babies one-to-one. We try our very best if we can. And our current baseline rate for unplanned extubations was 4.9 per 100 ventilated days. So the aim of our project was to reduce the incidence of unplanned extubations on the NICU by 30% through the implementation of an evidence-based care bundle for all of our intubated patients. So all of them were included. So just before starting this project, we actually changed our securement method from hat and ties to the NeoBar, which was a huge, huge change for us, and kind of is what kick-started this project. It got us looking really quite closely at our incidence of unplanned extubation. So what did we do? So multidisciplinary team approach and a pre-implementation staff survey. That was the foundation for this project, as I said before. We standardised incident reporting and analysis. So prior to this, our incident reporting was a bit sketchy of our unplanned extubations, and we weren't 100% sure what our baseline rate actually was. So that was the first step. A lot of awareness about why we had to be consistently reporting these. So we actually created a QR code for staff to complete a survey if an incident happened. And then we also logged that formally on our incident reporting database, which we use Radar here at the Evelina. And then our project team actually analysed all of those incidents, and that's how we established trends and trying to understand actually why were these incidents happening and why were we having so many of them. So that was our very first step, was actually trying to get some regular routine and some standardised baseline data. And we now, I would say about 99% at reporting our unplanned extubations. I don't think many go unreported, so we're doing a really good job. We created a driver diagram based off this data, so looking at what were our barriers and how we could potentially overcome them with change ideas that were going to be relevant to our unit. And this is our driver diagram here, you can see. And then from this, we developed a unit-specific care bundle. So there's a lot of care bundles represented in literature for preventing unplanned extubations, but we wanted to make our own that was relevant to our own themes and our own trends from our incidents that we've reported here. And this is how we came up with our care bundle, which is called Secure. So the S stands for Standardised Securement Method, which is our NeoBar. E, enlist a second person for handling and positioning, or it would also stand for extra hands. That was a very, very big change for us. And given that 75% of our incidents happen during staff handling, that was one of our biggest focuses for this project. C was consider comfort and containment. U was the unplanned extubation QR code for reporting, which I just mentioned. R was review the ETT position on board round, and E was escalate concerns immediately. So this is how we launched this project. So this is just some learning from our unplanned extubation data. So you can see that 50% of our unplanned extubations happen on a day shift and 50% on night shift, which we were surprised about. We thought that there would be a little bit more variation there. A third of our unplanned extubations happen prior to or during handover, which is between the hours of 6 and 8. 60% of our unplanned extubations occur in babies less than 30 weeks. So we knew that our extreme preterm population were particularly vulnerable to this incident. We know that 75% happen during handling, and that handling constitutes cares, x-rays, procedures such as line insertion, any form of staff handling. 27% of unplanned extubations occurred because of a problem related to the neobar. 50% happened in one particular room, but we know that we have more babies in that room, so the results are a little bit skewed there. And our unplanned extubations happen in our smaller populations, which I mentioned before. We've had one baby self-remove their breathing tube since we started this project, so it's hardly ever the baby's fault. Okay, so the elements of the care bundle were implemented using PDSA cycles, and that was key. We didn't just go in and overwhelm staff with a full, bunch of interventions. We started with one implementation at a time. So you can see that we started with our assessment, which was the QR code for reporting incidents and analysing our themes. We then created a calendar for reporting our incidents at the shift huddle. So every day at 10 a.m. we come together and huddle, and we talk about how many ventilated babies we have and whether there were any unplanned extubations in the previous 24 hours. So all staff can walk past that and it's highly visible. They can see exactly how we're going, red versus green. We did a secure and neobar awareness week. We tried to get as many muzzles as possible so that we could keep our babies wrapped, comfortable and contained. We standardised two-person positioning where possible. We established a new tape for our neobar, so we had a lot of staff feedback that the tape wasn't sticky enough. So we actually did a lot of research and came up with a new tape, which everybody seems to like. It's definitely helped. We did a lot of bedside education, so taking a trolley around and, going around to the clinical areas and actually taking the education to the bedside. And then we also share our data every month via email so that the whole clinical team are aware of how we're going. And finally, we've actually just modified the way that we are taking our neobar. I'm going to share a little video after this so that you can see how we do it. Oh, I'll come back to that. So this was an example of our secure and neobar awareness week. So we actually opened a neobar, all non-alcoholic drinks, of course. And we had the clinical staff come into one of our spare rooms, learn all about the secure project, how they can be involved, how they can help us to reduce unplanned extubations. And you can see that we have our champions there who are the ones actually doing the teaching, and getting this going. Here in the middle, you can see is Erin. She's teaching a couple of people how to apply the neobar, and some of our consultants at the end here who are enjoying the day. So it's a nice opportunity to come out of the clinical area and do a little bit of learning and have a bit of a relax. So here are our results. So you can see that we've had a nice downward trend since the implementation of this project. And you can see quite consistently where we've made various changes. And we've actually just now been able to reduce our median rate slightly. So we've definitely seen an improvement and we're all very happy and excited about it. But we know that sustained change takes time. This is going to be a forever project. We're always going to have to keep on top of this because we know that unplanned extubations are always going to be a risk for our tiny babies. Achievements. So we've achieved a multidisciplinary understanding of the problem and a coordinated effort to achieve shared aim. And I think that that's probably my favourite thing about this project, and it's something that can't be measured, is the shift in culture as a unit. We've gone from unplanned extubations happening fairly regularly to everybody actually coming together and going, okay, this is a problem, we're going to take it really seriously. And I'm not sure if you guys on the floor feel that way too. But that's probably been the nicest thing, and that's not reflected in our results, unfortunately. But I feel that everyone really cares about this, which has been great. You can see there's some of our staff members there enjoying the Neo bar. We've identified the highest risk population and have targeted our change ideas accordingly. So our extreme preterms are certainly our highest risk population. And we tend to try our best to, if we can do one-to-one care or if we can do two-person handling for this population, we try to prioritise them. We've reduced the number of incidents occurring during handling. So this has come right down, which is fantastic. But of course, we're constantly looking at our trends and our themes to try and get on top of this. So we had a bit of a blip recently where a few were happening during suctioning. So we looked really closely and did some education on staff suctioning practice. So we're always kind of altering our change ideas and what we're doing based on what's actually happening in real time. And of course, we've had a positive trend and our median line is now reduced. So in summary, unplanned extubations will always be a risk in neonatal intensive care. Accepting that sustained improvement takes time. This can sometimes be really challenging, particularly for those involved in the project. We feel really passionately about it, but we know that we just have to be patient. We're going to be embedding education in nursing and medical inductions and on the clinical floor. So this is going to be a constant, continuous thing to make sure that, this project is sustainable. And here you can see one of our nurses, Mel, who is teaching one of our resident doctors how to apply the Neo bar, which is great. So we love seeing that multidisciplinary collaboration. We're, of course, contributing to our national QI database, which is Safe Neo. And just remember that the key to successful change management is MDT involvement. People drive change, and this includes our nursing team. So I'd like to thank the Evelina Neonatal team for their hard work and contribution to the project. I'd like to thank Sandy Kirilos, who is the co-lead for Secure, and those involved in the project who have put in so much work to get these fantastic results. And here is one of our little preterm babies having